Okay. Good morning, good afternoon, good evening, wherever you're dialing in from, and welcome to our final case discussion and lecture series brought to you by the Samira Foundation. My name is Samira, and I am a patient living with seronegative neuromyelitis optica spectrum disorder. I'm also the founder and executive director of the Samira Foundation. We are a global nonprofit organization dedicated to raising awareness of NMOSD, MOGAD, and other rare neuroimmune conditions. We're very passionate about building communities of support for patients, caregivers, and clinicians. We fund research, fellowships, journal publications, and advocate on behalf of patients. Very proud to be patient-led, patient-powered, science-driven, therapy-agnostic, and especially reflected here today as an organization. We're also very passionate about diversity and global inclusivity. So earlier this year, Dr. Sara Samadzadeh, who is TSF's clinician ambassador of Germany and Iran, came to me and said, hey, I think this would be a great idea to bring educational programming from experts around the world to the Iranian community around the world. And of course, I agreed. And so together, we've been able to produce about 6 of these this year in English, no, it's all been in English, but
Well,
we've
English,
had
yeah.
speakers from France, from Italy, from Germany. So, and now we have a very special guest today, Dr. Eoin Flanagan. He's a household name in NMOSD and MOGAD. He is an expert, of course, in our diseases from Mayo Clinic, Rochester. So we're very happy to have him. And congratulations on an award to the NMOSD team at Mayo Clinic. They just won the Scientific Team Award. So this is incredible that we get to do this with you. Just lastly, this is being recorded and it will be available for replay on our TSF YouTube channel. And this is the last program of this series for the year. So thank you all for such a great year. Thank you for being part of this wonderful series. Thank you, Dr. Samadzadeh and Professor Sahraian. We've really enjoyed working with you, and I pass it off to you, Dr. Sara.
Yeah, thank you so much. Thank you. A special thanks to you because of the whole collaboration with us, with the Iranian community, neurologists, young juniors, neuroscientists in Iran. And thank you for a special guest of us today, Professor Flanagan. And also thank you to the whole audiences that we have. We had like such a nice and really great year 2024 altogether with me, Professor Sahraian and Samira, and all of our guests this year. And I think we will continue. We will try to continue the series for the next year, 2025. And we are now collecting the subjects and the topics that you're interested to be covered for next year. Please reach out to me and send the topics that you'd like to be covered in our series. And also if it is, it's like more interesting to have case discussion, we can also put together a case discussion with Professor Sahraian with the neurology residents and also neuroimmunology and autoimmune neurology fellows in Iran and as fellows, and we can discuss with all the experts all over the world. And thank you so much. It's my great pleasure to have Eoin today. And please, Eoin, you can start a great presentation. And thank you so much to be here today with us.
Thank you so much for the kind introduction, Sara, and great to see you all again. And thanks to the Samira Foundation for the opportunity today. I'm just going to pull up my slides here. Yes, so yes, today I'm going to focus my talk on imaging features of MOG, antibody-associated disease, and neuromyelitis optica spectrum disorder. These are some of my disclosures here, not too relevant to this talk, which will focus mostly on diagnosis. So when I think about distinct immune-mediated diseases associated with inflammatory demyelination, we think about the 3 major ones that we know of are multiple sclerosis, all its variants from radiologically isolated syndrome all the way to secondary progressive multiple sclerosis. We have aquaporin 4 antibody positive NMOSD, and then we have MOG antibody associated disease, and then we have many other conditions that fall into a category of what we sometimes term double seronegative, so double seronegative NMOSD, double seronegative recurrent optic neuritis, that are an area of important discovery, where we hope to discover new antibodies to add to this list of antibody-associated demyelinating conditions. And when we think about neuroimaging, and much of the talk today, I'll focus in on NMO and MOGAD, but we'll also compare a little bit to multiple sclerosis. Imaging is a major component of many of the diagnostic criteria for MS, where MRI lesions make up an important component. For neuromyelitis optica spectrum disorder, both within the criteria, particularly for the seronegative group, there are important aspects you need to meet on the MRI imaging, both in the spinal cord, optic nerve, or in the brain. And there are also red flags that are centered around some of the features that might suggest a different diagnosis than NMOSD. And then with MOGAD, if you have a low titer, or if you have a titer only or a positivity only in CSF, we often ask for additional supportive criteria, that many of which are radiological, that will support the diagnosis of MOGAD. And there are also red flags in the MOGAD criteria that highlight some imaging features. So we'll talk about some of those today to try and highlight what these look like on MRI. And one of the most important things to remember early on for physicians who are ordering a test in a patient with suspected optic neuritis, which is a common phenotype or attack type that we see, it's very important to order an orbital MRI with gadolinium and with fat-saturated images. Because what you can see here is this is just a regular brain MRI, and this patient had optic neuritis, but it would be quite difficult to determine which side was abnormal here on this this image, while when we compare to the fat-saturated image, when we zero out the white fatty tissue that we had, we can see active inflammation within the optic nerve, and it can help us confirm the underlying diagnosis. So very important that if you have an attack of the optic neuritis, that an orbital MRI is ordered with fat-saturated images, because that is key to clinching the diagnosis of an acute attack, and then that can direct you towards the correct treatment, or if it's the first attack, which type of antibody testing you might need and the underlying diagnosis. So what about if we think of optic neuritis? In multiple sclerosis, we don't tend to have as much optic disc edema. So when you look in the back of the eye, they don't have as much swelling. And oftentimes it's unilateral, and it's milder in severity. And the MRI will reveal a shorter area of enhancement, often extending just over a short part of the nerve, not more than 50%. There has been some studies showing that double inversion recovery can help identify T2 signals of old MS lesions within the brain, and this may be encompassed into new diagnostic criteria for multiple sclerosis. And what about MOGAD? Well, optic neuritis is really important in MOGAD because it's by far the most common manifestation, particularly in adults. Optic disc edema is quite common in up to 85% of patients. And this can be bilateral and often begins with pain with moving the eye and then subsequently vision loss. And the episodes are often severe, but they can recover well, particularly with steroid treatment. So here's an example. It's important that you have your fundoscope as a physician and you look in the back of the eye for these patients. And what you'll see is that the optic disc is often swollen. And sometimes you can even see hemorrhages and bleeding from severe swelling within the back of the eye. And sometimes even on MRI, you can see the swelling in the back of the eye where it's little bit less rounded here, and you can see kind of a little bit of swelling into the vitreous chamber here of the optic nerves. When you look at the MRI with fat-saturated images, what you'll see is the anterior part of the optic nerve is involved. So here you see this white enhancement in the anterior part of the optic nerve. And then sometimes that extends into the sheath. So you can get this kind of tram track appearance that looks like a train track. And then you can sometimes see the inflammation spread into the fatty tissue, like we can see here with the arrowhead. The lesions with MOG antibody-associated disease often tend to be long, so we see them extending more than 50% of the nerve. And if you see bilateral long lesions in the optic nerve with enhancement, then you really want to be thinking about MOG as your #1 most likely diagnosis. We can also see T2 hyperintensity within the optic nerve. Here you can see an example of T2 hyperintensity within the nerve, and the nerve becomes a little bit swollen and a little bit tortuous here compared to the other side. What about optical coherence tomography? Well, this is a different imaging technique where we use infrared laser and we can take a picture of the back of the eye, and it can help measure the thickness in the retinal nerve fiber layer and in the ganglion cell layer. And in conjunction with this swelling that we see when we look under in the back of the eye with our ophthalmoscope, when we measure out the retinal nerve fiber layer thickness, we see that it's thicker than normal. The normal is probably about 90 or 85 to 100. And here you can see it's 168 and 185. So in the acute setting, we can see a lot of thickening when we measure it with this OCT technique. And then in follow-up, what we tend to see is we see the optic nerves appear more pale, and we get optic disc pallor. And then when we measure those, the thickness of the optic nerves, they're now thinner than normal, being 59 or 60, where the normal is 85 to 100. And what you'll see is this differs from MS in that in the acute period, the thickness tends to be greater. So we see a median thickness of about 160 in the MOG, and even some patients having very, very thick optic nerves with severe swelling at the onset. While with MS, most of the time, it's not very swollen at all, the optic nerve. So that's a useful discriminator and can be an early clue that this is more likely to be MOG than MS. What about aquaporin 4 antibody positive NMOSD? This one's a little bit different to MOG. MOG involves the anterior part of the optic nerve, and this one involves more the posterior part of the optic nerve. And here we can see the posterior optic nerve enhancement here. And here we can see enhancement extending into the optic chiasm that we sometimes term optic chiasmitis. So the posterior part of the optic nerve. And then other times we can see just a longer lesion extending along the nerve, over 50% of the nerve again, and often involving that posterior part of the optic nerve. So we tend to see less swelling with this because the inflammation is more posterior and not right up at the top of the eye where the inflammation leads to swelling. Again, these episodes tend to be severe and they have intermediate or poor recovery, so less recovery than we see with MS or MOGAD. What about T2 signal in the spinal cord? So when somebody has inflammation in the spinal cord that we term myelitis, we tend to see, we look at these images that we call the sagittal T2 weighted images, and we're looking for evidence of a lesion. And here the lesion is depicted in red, and this one extends 2 vertebral segments, and our cutoff is generally 3 vertebral segments. So if we see a lesion extending over 3 vertebrae, so you can see your vertebrae here, if it's longer than 3, then we're suspicious for NMO or MOGAD compared to MS, because the MS lesions are usually short. Now, sometimes that imaging can depend on the timing. So if you image early on, you may see a lesion that's starting to grow, but not fully formed yet. And then here after 1 day, you see a little bit of a lesion extending from the brainstem down into the spinal cord. And after 2 days, it's getting bigger. And after 12 days, it's a longitudinally extensive lesion extending more than those 3 vertebral segments. The other thing to remember is that sometimes the initial MRI can be normal, so you can have a little bit of a lag where the MRI lags behind the clinical symptoms. So this was a patient who had symptoms of a myelitis, but the initial MRI was normal. We did a spinal fluid and there was evidence of inflammation, and we repeated the imaging 7 to 10 days later, and we then saw the signal abnormality. So in about 10% of patients, the signal abnormalities can be delayed with MOGAD and the initial MRI can be normal. So you got to be careful if the initial MRI is normal, but you're still suspicious of a MOGAD attack. And sometimes you can see with MS, you can see that if you look on the axial images, what you'll see is that you'll see multiple short lesions, but they look longitudinally extensive when they're piled up on top of each other. But on the axial images, they're clearly separated from each other. So sometimes you'll think you're seeing a long lesion, but actually it's just multiple short lesions back to back from each other. So what about MS lesions? Here we see an example of an MS lesion in the back part of the spinal cord at the C2 level. We see some slight ring enhancement and we see the periphery of the spinal cord involved. That's pretty typical of multiple sclerosis. Now with multiple sclerosis, you can sometimes see that one lesion will cause a lot of thinning in the spinal cord and you get this atrophy. And sometimes that one lesion will cause clinical symptoms and patients will develop progressive disease on one side related to that lesion. So they'll get progressive left-sided weakness just related to that lesion. They may have other lesions, but most of those lesions will be silent. So one lesion in the spinal cord can really lead to this progressive form of MS. So it just highlights the importance of the spinal cord in these conditions. And this was an editorial about this, highlighting location, location, location. The spinal cord is not a very forgiving place to have inflammation. And some patients can just have one lesion and they don't fulfill the criteria for MS, but they have a typical lesion of MS. They develop atrophy, they might have oligoclonal bands, and they develop progression from that lesion. So what about in MOGAD? The myelitis episodes tend to be long. About 70% or so, or 75%, will have a long lesion extending more than 3 vertebral segments. And one clue on the axial images is that it tends to involve the central gray matter. So we sometimes term this the H sign, which we can see here. We can also commonly see conus involvement. So here we can see involvement of the lower spinal cord. And many of these patients will get bowel and bladder impairment and erectile dysfunction associated with that bottom part of the spinal cord where many of those things are controlled. And again, the MRI can be normal early on. So sometimes when I'm teaching the residents, they're looking out for this H sign, I teach them it might look like an Under Armour depending on your lineage, or if you're more of a Star Wars fan, it looks more like the TIE fighter. So this H sign is a helpful clue to MOGAD. Another thing we can see here, this is the lesion in aquaporin 4 antibody positive NMOSD, where we see a longitudinally extensive lesion extending more than these 3 vertebral segments. And sometimes we can see a very bright area in the middle of it that we term a bright spotty T2 that looks almost like something we call a syrinx or a fluid fill cavity within the lesion. And that's a clue to aquaporin 4 antibody positive NMOSD. And then other times we'll see this T1 hypointensity like we can see here. In about 15% of cases of NMOSD, we can see shorter lesions that are, you can see this one is about 2 vertebral segments. So we can see shorter lesions in that condition, but less commonly. And then sometimes we'll see this elongated ring of enhancement. Here you can see a slight ring here. Here you can see another ring of enhancement. We do sometimes see that with multiple sclerosis also, but we don't tend to see it with sarcoidosis or some of the other myelitis mimics. And here you can see an elongated ring of enhancement that we sometimes think looks like the Eye of Sauron from Lord of the Rings. So you can see here and this elongated ring of enhancement in some of these patients. We've also seen that some of these patients can have a dilated central canal. So here you see an example of this. You see this kind of linear appearance on the MRI, and then on the axial images, you'll see the central canal dilates during the myelitis, and then in follow-up, it tends to go away. And we think that that's just a potential space. Some people, their central canal remains open within their spinal cord, and when they get inflammation, it swells up a little bit more and then goes down. But it's not really highly specific. We can see it with MOGAD, we can see it with NMOSD, and we can see it with other causes of myelitis. But we don't tend to see it with MS because MS tends to involve the outside of the spinal cord rather than the center. Here we see an example. Yeah, this was aquaporin 4. This one was MOGAD. Again, we can see this central canal involvement, while with MS, we see more of the peripheral lesions. So let's just do some comparisons here. So here we can see a long lesion in MOG antibody-associated disease. We can see not too much enhancement or sometimes faint enhancement. And then on the axial images, we see it involves the central gray matter forming this H sign. With aquaporin 4, we tend to see a more swollen cord. It looks a bit more angry, and we see more enhancement within the spinal cord. And then on the axial images, we see T2 hyperintensity within the entire central cord. But there is some overlap, and sometimes MOGAD acute myelitis can also look like this. And then with MS, we have these shorter lesions that we showed earlier. What about the brain lesions? So if we just think about MS first, we talk about these inferior temporal pole lesions that are quite suggestive of MS. We talk about Dawson's fingers, where we get these T2 hyperintensities perpendicular to the ventricle. We have here ovoid periventricular lesions that are pretty typical of MS. Here we can see enhancing lesions within the brain, typical of MS, and then we can see lesions adjacent to the cortex called juxtacortical T2 lesions. And then the infratentorial space here we can see in the dorsal pons, we can see T2 hyperintensity in a patient with double vision likely from that lesion. And then sometimes we can see this T1 hypointensity over time. With advanced imaging, there's been more interest in the central vein sign, which can help suggest MS over other etiologies. So you see a vein that's going through the center of the lesion like this, or If you look at it a different way in cross-section, it can be at the center of the lesion. While with small vessel disease or migraine, we don't tend to see those changes. And then sometimes we can see this paramagnetic rim lesion when we do this sophisticated SWI imaging, where we see this rim around the lesion. So that can be suggestive of MS. We don't tend to see those as much in MOGAD or NMOSD. And here you see an example of an NMOSD case where we don't see those rim signs. What about in MOG antibody disease in the cerebellum? So it's a bit different to MS in that when we see the cerebellum or the brainstem involved, it tends to occur in the setting of multifocal brain involvement. And the symptoms often are encephalopathy, and they may not have just isolated brainstem or cerebellar symptoms. With MS, that's common to have isolated brainstem, but with this, we don't tend to see it as much. And here we see the lesions tend to be larger, and they're a bit more ill-defined. We sometimes call them fluffy lesions within the brainstem. Here we can see diffuse lesion within the pons. Here we can see a large lesion within the middle cerebellar peduncle or in the dentate on the opposite side, compared to the MS lesions, which are smaller and more peripheral within the brainstem. The brain lesions, this is a classic image of MOGAD. We can see here a white matter T2 hyperintensity here. And here we can see deep gray matter involvement in the basal ganglia and in the thalamus. And again, some of these lesions are more indistinct and poorly marginated. We can see corpus callosum involvement in MOGAD, but it tends to be larger, not these slim Dawson's fingers, but more extensive corpus callosum involvement in MOGAD. And then sometimes in MOGAD, we can see what we call leptomeningeal enhancement, which is the covering of the brain, the arachnoid and the pia can show some inflammation. We don't tend to see that in MS. And sometimes the posterior fossa enhancement can mimic something called clippers, which is another steroid responsive condition that can look like this. Again, different to MS, where you would have these ovoid periventricular and inferior temporal pole lesions. And also the larger lesions in MS will sometimes form this cyst where you get a T2 hypointense rim. You can get an arc of restricted diffusion, and you can get an open ring of enhancement, or these Bailos concentric rings of hyper and hypointensity. So all of these features are suggestive of MS. If you see a larger lesion, what we call a tumefactive lesion, or a large lesion in the brain that looks like a tumor, we see these features that are suggestive of MS. But we also see these large lesions within MOGAD, particularly more commonly indeed with MOGAD. There is an interesting new syndrome with MOGAD called cerebral cortical encephalitis, where you can get unilateral swelling of the cortex and T2 hyperintensity. And sometimes you can also have hyperperfusion. And this has been termed flames sometimes, which is unilateral cortical flare hyperintense lesions in anti-MOG associated encephalitis with seizures. It's quite a mouthful of a name, and I think more commonly we're using the cerebral cortical encephalitis terminology. This is an example that we, Dr. Lopez Chiriboga, one of our excellent neurologists at Mayo Clinic Jacksonville, diagnosed based on the imaging. And here you can see this unilateral T2 hyperintensity and swelling with some leptomeningeal enhancement. And here we can see T2 hyperintensity and swelling, a little bit more subtle in this case, in the posterior aspect that was cerebral cortical encephalitis. And sometimes adjacent to the swelling and the T2 hyperintensity within the gray matter and the cortex, you can see adjacent white matter T2 hypointensity or darkness in the white matter. It's important to recognize that there have been reports of some patients with what we call fulminant or very severe life-threatening attacks in MOG antibody-associated disease. There are reports now suggesting that up to a quarter of patients with cerebral attacks can have increased intracranial pressure. So their pressure goes up in their spinal fluid and in their brain, and that can be problematic. And here you see an example of a very swollen brain. And this patient, the pressure from all this swelling and what we call edema was pressing down on the brainstem and causing damage. So they had to temporarily remove this patient's skull in what we call a hemicraniectomy as a life-saving maneuver. But once they did that, and once the patient got their inflammation treated and got their attack treated, they were able to put back on the skull and the patient survived. Because sometimes if the swelling gets so much in the brain in that compartment and it can't go anywhere else, it can cause you to herniate and people can die from that. So it can be very serious. Here's another example where the pressure and swelling in the brain was pressing down. You can see the brain stem and the cerebellum are getting pushed down into the spinal cord here. And this is a really dangerous situation. And in this situation, they use this anti-IL-6 or tocilizumab treatment, which can be used in the acute situation. And that seemed to work well in this scenario. So as I mentioned earlier, we can see this elevated intracranial pressure in 20 to 25% of the cerebral attacks. And sometimes we have to use heroic measures, like we can give people diuretics to remove all their fluid. We can put in a drain, a neurosurgical drain, or we can give other treatments that can really try and reduce the pressure quickly. And this sometimes has to be done in an intensive care unit, like a neurology intensive care unit. And when you have this increased intracranial pressure, it tends to lead to a longer hospital stay and worse outcomes. So it's important to recognize. What about other involvement in MOGAD? Well, sometimes the MOGAD inflammation in the lower spinal cord can extend into what we call the cauda equina, which is the nerve roots that come out from the bottom of the spinal cord. My colleague, Dr. Dubé, highlighted that sometimes if you stain the MOG protein, you can see that it sometimes extends from the central nervous system. We really think of MOG as being present in the central nervous system, which is the spinal cord, the brain, and the optic nerve, but not so much in the peripheral nervous system. But some of the MOG will extend out into the nerve roots, that, like we can see here, and that might be why we see some of this inflammation can sometimes spill over. We can also see people with a more meningitis-like presentation, so they present like an infectious syndrome involving the coverings of the brain that we term meningitis. Or other times we can see this will mimic something called pseudotumor cerebri, which is a condition associated with headaches and increased pressure in the brain that can sometimes look like this. And it's important to think about MOGAD in that situation. You have to be cautious because the MOG antibodies are a little bit sticky, so sometimes we can have false positive results. So you got to be cautious because sometimes other things might be reported with MOG antibody disease, but it might be a low positive and not mean anything. So you have to be careful. It might be a false positive. As we know, MOG antibody-associated disease disproportionately affects children. They account for about 20 to 25% of new onset cases. And when you do studies of brain MRIs in children, what you'll see is that the MOGAD impacts the growth of the brain and that you can get atrophy in different regions, including in the thalamus and the gray matter. And sometimes what you'll see is damage within the white matter. Here we can see this, what we term leukodystrophy-like pattern with quite a bit of damage in the white matter from one or more attacks of MOGAD. So what about aquaporin-4 antibody positive NMOSD? Well, with the aquaporin-4, it's actually highly localized in the brain here. Across the brain stem and in what we call these circumventricular organs. And it's interesting that the lesions, what we see in MOGAD, tend to follow that region. So sometimes we see them adjacent to the lateral ventricles. We can see them adjacent to the third ventricle or the fourth ventricle. We can have involvement of the dorsal medulla, which is the back part of the brainstem. And this is the vomiting center of the brain. It's sometimes called the area postrema region. And some of these patients will get nausea, vomiting, and hiccups as their first manifestation. And they might not see a neurologist right away, and they may end up seeing a gastroenterologist for their nausea and vomiting. But it's important to think about this because nausea and vomiting can be a manifestation of this NMOSD. We can also see involvement of the cerebral peduncle, which is the midbrain, and we can see the lesions extend into the internal capsule with NMOSD. We can see involvement of the splenium of the corpus callosum in what we sometimes term a bridge arch pattern, where it forms an arch. And then we can see enhancement within this region that we sometimes call linear ependymal enhancement that's consistent with NMOSD. We can also see NMOSD in children. Here's an example of a child with optic neuritis involving the optic chiasm here. We can also see lesions within the third and fourth ventricle or in the area postrema region here. And we can see long lesions within the cord. And sometimes in children, the brain lesions can be a little bit larger. So sometimes you'll see these large fluffy lesions in children. We recently did a study, Dr. Donato, who was working with us coming from Verona, showed that you can have T2 hyperintensities within the dentate nucleus and the cerebellum here in NMOSD. And it's important because the cerebellum wasn't specifically mentioned in the prior diagnostic criteria. So it's going to be important for the future to remember about these cerebellar lesions that can occur in MOGAD. That's about 4% of patients. We talked earlier a little bit about the MRI and the radiological lags. So what we sometimes see in a MOGAD attack, this is a patient who presented with encephalitis and the initial MRI was completely normal. And then you do an MRI 15 days later and you'll see 20 or 30 lesions. So this is important to recognize that the imaging may lag behind the clinical deficits, but also it may be accompanied by worsening. As they get more lesions, the patients may get worse. Here we see an example. The first MRI showed a single lesion. We did an MRI 16 days later, and now we see 10 or 15 lesions. So the MOG is very dynamic and tends to change a lot, even over short periods of time. Here we see an example of MS. We can see a periventricular T2 lesion, and we see over time that the lesions are more stable. We can see the same lesion. Sometimes it's enlarged a bit, but we don't tend to see many new lesions form. But over time, we can see new lesions can form over long periods of time. But overall, the MRI usually stays fairly stable within the attack. And then here we can see aquaporin 4 positive NMOSD, where the lesions were essentially stable during the time of the attack. So the MOG tends to be much more dynamic and changes a lot during attacks. Also, the other thing to remember is multiple sclerosis. The term means multiple scars or multiple plaques. So the MS lesions, when they come, they tend to leave a scar and they don't resolve completely. That's a bit different to MOGAD, where here we see multiple different lesions within the brain. And then in follow-up, many of the lesions have resolved completely. And there's just a tiny bit of residual T2 signal here. In pediatrics, here we see a T2 lesion in the thalamus, and then it's completely resolved. Here we can see with MS, T2 hyperintensities in the periventricular region, and we can see here some T1 hypointensity. And again, with MS, we see these periventricular lesions that tend to persist over time. So the MS lesions will persist over time, while the MOGAD lesions will resolve. And then with aquaporin 4 NMOSD, we see the lesions also persist over time, differing from MOGAD, where the lesions resolve. Sometimes, even if we image patients outside of the acute period of their acute attack, we can see ongoing enhancements within the nerve. Dr. John Chen at the Mayo Clinic published some studies here with Shaili Shah and Dina Tajfru, and they showed that you can have ongoing inflammation at the site of prior inflammation. So usually it's residual inflammation at the site of prior inflammation rather than new sites of inflammation. But it's important to recognize, because if you do an MRI and you think the patient might be having an attack, it could just be residual from the old MRI. We don't know why it happens. Maybe there's ongoing blood-brain barrier breakdown and incomplete recovery from prior episodes, or maybe there is some ongoing optic nerve inflammation between attacks. And here's some examples they had from that study. You can see here a big, thick optic nerve enhancement in the setting of an attack, and later on, outside of the attack, we see a little bit of ongoing enhancement. Here we see again a posterior involvement of the optic nerve, and then a little bit of residual enhancement later on. And if we look at the spinal cord, here we can see a MOG lesion, long lesion in the pediatric patient, this H sign, and then in follow-up, the lesion completely resolves, which is pretty typical of MOGAD. About 80% of patients, their lesions will resolve. With aquaporin 4 positive NMOSD, we see a long lesion here. And then in follow-up, the spinal cord is a little bit smaller, so it's lost some of its volume. There's some atrophy. And then we can see this ongoing T2 signal within the cord. And we can see that also here in the axial images. And with MS, we see a shorter lesion. In follow-up, the lesion reduces in size a little bit, but not quite as much as the NMOSD. And then we see residual T2 hyperintensity within the right side of the cord here. And this might contribute to some of the attack types that we think about with MOGAD. So with MOGAD, we know that when you have an attack, what you'll see here is disability on the y-axis and time on the x-axis. And the attacks tend to be severe, so patients may be wheelchair dependent during their attack, but then they can recover completely and the lesions disappear. So some of this better repair in MOGAD may be why they recover so well. And after each attack, they tend to recover well, although with each attack, they'll lose a little bit of ground, so they do get ongoing disability. So it's important to prevent those attacks if you can. With aquaporin 4 positive NMOSD, the severity after each attack tends to be worse. So After a first attack, a patient may be dragging one leg. After 2 attacks, they're using a cane. After 3 attacks, they're using a walker. And after 4, they're wheelchair dependent. So we tend to get a lot of damage with each aquaporin 4 positive NMOSD. And then with MS, the attacks tend to be milder, but those persistent scars, we can hypothesize at least that they may contribute to this later progressive course that we see in multiple sclerosis. So what we know in MS is that one of our standard of care is that we follow imaging over time to look for new lesions developing. And this was a study that we did, and others have also done, looking at the frequency of new lesions that are asymptomatic, so silent new lesions if you do an updated MRI. And in MS, what we found was this was found in 54% over the course of a few years. These were mostly patients on lower efficacy medications. This was from many years ago, so it might be less now in the setting of our stronger medications. But with MOGAD and aquaporin 4 positive NMOSD, many of these MOGAD patients were not even on any treatment, and they didn't tend to develop new lesions. So there may be less subclinical disease in MOGAD and aquaporin 4 positive NMOSD, or it may be that there's lesions coming and going, that we know that the MOGAD lesions resolve. So maybe between 2 MRIs, there was a lesion coming and then going away between those 2. But this is important implications for clinical practice, because in general, we don't recommend that patients with MOGAD or aquaporin 4 positive NMOSD have ongoing surveillance imaging, while with MS, we do. So if we can summarize some of the features we talked about today, with MOGAD, we can see these long lesions within the optic nerve. We can see inflammation along the sheath spreading into the fatty tissue. And we can sometimes see optic disc swelling on our MRI, or if we look in the back of the eye, and it tends to be the anterior part of the optic nerve involved. With NMOSD, we tend to see the posterior part of the nerve involved and more chiasm involvement. And then with MS, we see shorter enhancing lesions along the optic nerve. Here we can see with the spinal cord, we'll see this long lesion with MOGAD. We can sometimes see the conus involved. And then on the axial imaging, we'll see this H sign where the central gray matter is involved. And then in follow-up, the lesions resolve completely. With aquaporin 4 positive NMOSD, we see a long lesion. We see a central lesion on axial images, and then in follow-up, the lesion persists and is left over, and there can be some thinning of the cord. And then in MS, we can see multiple different lesions here. And then over time, they tend to develop new lesions, but none of the lesions go away. And sometimes they can develop atrophy within the spinal cord too, focally, like we see here. And what about the brain lesions? With MOGAD, we tend to see larger lesions in the medulla or pons. We can see large lesions within the unilateral or bilateral cerebellar peduncle. We can see involvement of the thalamus or basal ganglia, and we can see white matter involvement. And then we have this cerebral cortical encephalitis phenotype where we see the swelling and T2 hyperintensity of the cortex, and then leptomeningeal enhancement. And then follow up, all of these lesions mostly will disappear completely. And with aquaporin 4 positive NMOSD, we can see involvement of the dorsal medulla. We can see involvement of the dorsal pons, and we can see involvement of the splenium of the corpus callosum or the internal capsule. And sometimes we'll see this ependymal enhancement that we showed earlier within the ventricles. And then with MS, we see shorter lesions within the brainstem. We'll see some of them that are periventricular. We'll see that they can have ring enhancement. And in follow-up, all of the lesions persist, and indeed new lesions will often appear, particularly if the patient's on lower efficacy medications. So I think I can stop there, and I'll open it up for any questions. I'd like to just acknowledge our neuroimmunology team at the Mayo Clinic. There's an overrepresentation of Irish people here, Dr. Sean Piddock, Andrew McKeown. There's many different Irish here, and there's many different collaborators that we were involved with in some of these studies. We've received funding from the Center for MS and Autoimmune Neurology at Mayo Clinic, from the NIH for an Aura-1 on MOGAD, and we've collaborated with the network of pediatric multiple sclerosis centers to do some MOGAD research also. So I will stop sharing, and maybe I'll open it up in case there's any questions.
Thank you so much for the excellent talk today, and I would like to introduce Professor Sahraian to you, and he is a vice chair of MS Society in Iran, and he's responsible for NMO and MOGAD clinic in Sina Hospital in Tehran. And please, Professor Sahraian, we are open to questions in here in the box and also Q&A. And please share the question with me, and I will read it to the audience. And please, Professor Sahraian, you would also maybe have some questions as well.
Thank you very much, Sara. Thank you very much, Professor Flanagan, and thanks, Sumaira, for the excellent presentation. And I would very much like to thank all of you on behalf of Iranian MS Society and also the people with NMOSD and MOGAD actually for having these sessions, which are very, very actually informative for our neurologists and the people who are visiting such patients. Thank you very much, especially a special thank to Professor Flanagan. You actually answered some of our questions which we had in clinical practice. One of the most important one was actually that whether we have routine follow-up MRI in patients who are under treatment with MOGAD and NMOSD, and you raised this slide that there is no need actually to follow them with MRI, and if we see any asymptomatic lesion. The question is actually, what is the role of imaging in choosing a different treatment for patients with MOGAD or NMOSD? For example,
did we lose the audio there for a second? Well, can we wait a second? I think he's coming back.
sorry. Yeah. Sorry for the interruption.
Yes.
Professor Flanagan, the question is actually, is there any role for imaging for choosing the treatment in MOGAD and NMOSD? For example, in MS, if we see baseline gut-enhancing lesion, if we see, for example, a spinal cord lesion, we go to higher efficacy treatment. But for MOGAD or actually NMOSD, is there any specific imaging pattern to choose different types of medication? Like, for example, we prefer to use eculizumab or rituximab, or for example, albumin in such imaging pattern, or we actually decide only from the clinical presentation? Thank you.
Yeah, excellent points and excellent question. So one thing I'll comment on just first, you mentioned about the repeat imaging. Sometimes a one-off repeat imaging after the first attack is useful to see all those lesions resolving, make sure you're on the right track, and to re-baseline things. So sometimes I'll do a first follow-up MRI and then not follow it after that. I think most of the clinical decisions in MOGAD will be based on the clinical aspects. The thing I look for, because I suppose up to half of patients with MOGAD can have a monophasic or one-off episode, we don't want to put all those patients onto long-term immunotherapy with the risks and the costs involved. But in patients who don't recover well, for example, if they have optic neuritis and then you treat them and they have residual blindness in one eye, then they're very vulnerable because we know that the optic nerve is the most common localization. So in some of those patients, we'll start them on a treatment. Alternatively, if they have a very severe attack, like those ones I mentioned that was life-threatening, those patients I tend to consider starting on a treatment. The other thing to mention is that there are clinical trials available in some regions of the world. So I think we've been very successful in neuromyelitis optica developing many treatments. And I think the hope would be that we could enroll patients if there's sites available for people to try and enroll them into clinical trials for MOGAD, because that's going to be quite important going forward.
Thank you very much. Thank you very much. Very informative. The second question, actually, we have, I take this opportunity having you and ask something about treatment. There is a controversial issue about treatment of MOGAD patient with rituximab. Actually, there are some publications that rituximab is not as effective as NMOSD in MOGAD patient. What do you prefer? Actually, in our country, at the moment, we cannot check MOG antibodies on cell base. if we have a patient with diagnosis of overlap disease, we don't know whether the patient is MOGAD or NMOSD, seronegative NMOSD. Do you prefer to start rituximab in this patient, or you prefer to use actually anti-interleukin-6, tocilizumab, or something else? This is one of the major issue in our country.
Yeah, it's a great point. So one thing I would say, if I think the overlap is between MS and MOG, and I'm not really sure if it's a false positive or not, I think that's a situation where I would use a B-cell depleting agent, and that might depend on what's available in your region. Like rituximab, a biosimilar would be fine, or in other regions it might be different B-cell agents. If the patient if you think it's MOGAD, and you're pretty sure, but you don't have the antibodies available, you know, my favored treatment would be either IL-6 blockade. That would probably be my number one, just anecdotally and based on some research studies, or potentially IVIG. So tocilizumab or biosimilars might be more available in your region. Satralizumab is involved in one of the clinical trials for MOGAD, so that hopefully might prove worthwhile. But I think they have similar mechanisms, so tocilizumab would be a reasonable choice, or maintenance IVIG, but that's quite expensive and that's not really available in many regions. And even in our region here, it can be quite difficult to get insurance to cover it and things like that. So I think some of those things can be a challenge. But I would favor the IL-6 blockade if I think it's MOG. It's hard to know if it overlaps with NMOSD. You know, there's also some suggestion that the live cell-based assay may be a little bit better than the fixed. So if you have access to a live CBA, or you can send it to a research lab, then that might help you confirm it's MOG. And then I think if you confirm it's MOG, then I would be going down the pathway of the IL-6 blockade. Yeah.
Sara, I think we have a question in the box.
Yeah. I think this is relevant to this question and this topic. It's who actually asked that, thank you for your valuable presentation. Do you think that MOGAD diagnosis beside clinical features should be mostly based on imaging features instead of antibody detection due to conflictual finding like false positive?
Yeah, I don't think so, because there's a lot of overlap between aquaporin 4 antibody positive NMOSD and MOGAD in terms of imaging features. There's less overlap with MS, and I find what helps me distinguish a false positive, because most of them is a question of MS or MOG. The two best things to help you distinguish are the presence of oligoclonal bands, and then the follow-up MRI showing that if the lesions are persisting, because if all the lesions persist, then it's very likely to be MS. While if more than 2 lesions resolve, you're almost certainly going to be MOGAD. So those two really help me. But I do think that the antibody is the way to go, because that's kind of mechanistically that you know what disease you have. And with the aquaporin 4, we got lucky because it's a really, really reliable test, and we don't see any false positives with the cell-based assay, really. So with the MOG, it's a little bit harder because it's a bit more sticky. So we do have to use our clinical judgment there. So I still prefer the MOG antibody testing. You know, there might be a role for CSF MOG antibody testing in the future, where if you're positive in both compartments, you're more likely to have MOG. There's some reports of isolated MOG CSF positivity, but studies are a bit conflicting there. So I think we need more data on that. So yeah, there's more to learn, but I do think the antibody is the key. So I would try not to replace the antibody with imaging or something like that. I don't think we have any other biomarkers that are as specific. And what you'll see is that if you see MOG antibody really high titer, they're super reliable. All of those patients will have classic MOG. So I just think that it's a little bit challenging at the lower levels, because if we raise our cutoff, we'll miss a lot of cases. So we have to kind of have that balance. So that's a challenge. Yeah.
Thank you so much. I have another questions. Okay, go ahead, Professor Sahraian.
If we go back to the imaging, in older publication, we had actually in MS, we had a term of normal appearing white matter. And there was some saying that we can actually use this normal appearing white matter to differentiate MS and NMOSD, because if you do MR spectroscopy in normal appearing white matter, we may have some differences. Is it still valid, and we can differentiate between MS and NMOSD with normal appearing white matter or not?
I think that that's a reasonable thing to look at, but it's probably not available in many places that you would have that type of sophisticated imaging, and it's probably not as reliable as some of the other things, like you have your oligoclonal glands, very readily reliable. You have the morphology of the lesions, you know, are they ovoid, periventricular, or do they look like more like NMO with the third and fourth ventricle? So it might be helpful if you had it available, but not perfect. You know, the other things would be the central vein sign would help you discriminate, or the paramagnetic rim sign might be a useful discriminator. I don't think we have much evidence yet in MOG antibody disease. My suspicion is that I suppose in the areas where the lesions resolve, that there's probably changes in that white matter.
Yes.
I think so. It may not be, it may look normal on the MRI, but it's been previously affected. So I think we'll have to discriminate whether there's regions that have been previously affected and then regions that were unaffected. What do they look like? So lots to learn in MOG for that. Yeah.
Thank you very much.
So I have another question here about the sequels of in a MOGAD patient. Do you see sequels in optic neuritis after enough treatment, like plasmapheresis or corticosteroid therapy?
I wonder, is this getting at like early recurrence or early relapse in this setting? I wasn't sure the exact meaning of the sequels.
I think it's just like a complication or remnant of the optic neuritis after like a treatment. Maybe it's just like a.
Because I think what we can see is that if you use steroids and you, for example, use a quick course of steroids and then you stop immediately, some of those patients will have a rebound of the optic neuritis even within the same month. So it wouldn't count yet as a new attack, but there's a recurrence. And that's why some people have been keen to use a bit of a steroid taper after attacks. So now some people will use up to a year of higher dose steroids, and I think that's problematic from a side effect standpoint, particularly with children, because patients hate oral corticosteroids. They get lots of side effects. So we've tried to kind of not have too long a taper, like maybe 6 weeks, 12 weeks, 4 weeks, 4 to 12 weeks, I suppose. We're not really sure. But so sometimes that steroid taper can be used to kind of try and prevent any early relapse, but also limiting limiting it. What would I say? Limiting it from a side effect standpoint, and then you know, if it's the second attack or the third attack, we might just end up changing their immunosuppressant and not using prolonged steroids. For the plasma exchange, there are some studies now. There's one from Germany that just came out that showed a pretty good utility of plasma exchange in acute attacks, and some data was presented from our group for a multi-center study that also showed plasma exchange seemed to have use. So I think it's important to think about plasma exchange if you're not recovered early on, or even if it's a very severe episode, particularly with the aquaporin 4, you might want to consider it even right up front.
Thank you so much. I have another question here. In the setting of seronegative optic neuritis with severe disc swelling, our neurophthalmologists cannot recognize anterior ischemic optic neuropathy from severe MOGAD attack. What's your approach and what's your opinion?
Yeah. So actually we're increasingly recognizing MOGAD in patients who are older than 50. We're seeing more and more cases that can mimic the acute ischemic optic neuropathy. I think there's some clinical differences. You know, the ischemic optic neuropathy does not tend to cause pain with eye movements, so that can be a clinical clue. It tends to be more altitudinal visual loss rather than central with MOGAD, but altitudinal with, and sometimes it comes on first thing in the morning with the ischemic optic neuropathy. And then if you look in the eye, if it's unilateral ischemic optic neuropathy, a lot of times there's a disc at risk on the other side with a small cup to disc ratio. So that can help you. And then your MRI of the orbits is going to be super helpful, because if you see enhancement of the optic nerve, that's going to strongly favor MOGAD, while with ischemic optic neuropathy, we don't tend to see enhancement. So I think I would be watching out for it. I do think we're underrepresenting it and we're missing it in older people. So I think I would have a lower threshold for doing the MRI if that's available to you, to try and figure it out, particularly if you know, there's pain with eye movement, there's not a whole lot of other vascular risk factors or things like that. Yeah.
Thank you so much. I don't have any other questions. Dr. Sahraian, do you have any further questions, comments, and remarks?
Thank you
here's
very
it's
much.
one more in the chat. Maybe is there?
The other
Or in
one,
the Q&A part. Question.
Would you rather initiating tocilizumab for refractory NMOSD not responding to rituximab, or add azathioprine to rituximab?
Yeah, for me, in general, I prefer to try and use one immunotherapy at a time and not load up additional ones. So I think I would try and change to a different mechanism from rituximab to potentially tocilizumab. Or, you could switch back to azathioprine. I think the data suggests probably that rituximab, tocilizumab might be a little bit stronger than the older generation medications. And those older generation medications usually require 6 months of steroids, and they have long-term risks of lymphoma and things like that. So I would prefer some of those infusion-based medications if you have them available. Yeah.
Okay, thank you so much. I think Dr. Sahraian is back now. Just a minute. Okay, so thank you so much for the great talk, great discussion, and excellent presentation. So we will put the presentation and the discussion on YouTube. And thank you so much for accepting our invitation today. Thank you, Samira, for this opportunity. If you have any comments or anything to add. Okay.
It's been a really wonderful year of listening and learning from experts around the world, and we're so grateful. And
Exactly.
hopefully for the audience, it's been helpful.
It's great you guys are doing this. So good to educate everyone around the world. Yeah, so important. Yeah.
Thank you so much for accepting our invitation, Eoin, and also maybe we'll ask you again here for another webinar in 2025.
Update or whatever. Yeah. Happy to help.
Back
Yeah,
and forth
of course.
with the emails, but thank you so much for the excellent presentation. So have a nice weekend, all of you. Okay, Dr. Sara is back. Yeah. Okay, so
no,
have a
thank
nice
you very much,
weekend.
all of you. Thank you.
Okay,
It's
thank
okay.
you.
Go ahead, Sara.
No worries. Thank you so much, and have a nice weekend, all of you, all over the world. Yeah.
Thanks, everyone.
Thank
Thanks.
Thanks.